That's good. For those of you who don't know me, I'm Caitlin. I'm one of the final years. So the topic I've been given for today is to talk about palliative care, which is end-of-life care is sort of part, but not all of palliative care, and then caring for people with a disability. And I picked this topic because I thought that it was taught really badly for us in fourth year. So I've tried to structure it in a way that I hope is helpful for the exams and the OSCE and also a bit for real life. So why are we learning about this stuff? Really, it's important in real life, regardless of what specialty you're interested in and what you end up doing. You will have people who've got incurable illnesses that are going to steadily get worse over time. You will have people who are dying, and you will have people with disabilities that you need to deal with as well. So you need to know these kind of skills for real life. It can come up in the exam, and anything that I think is like good exam content, I've tagged with this book. And it did last year. We had some multiple choice questions in our exam on palliative care stuff in the GP section. And it can come up in the OSCE as well. And it would be a really good way for the faculty to test your interpersonal skills and how you communicate and all that kind of stuff, because obviously that's really important when you're having these kinds of discussions with patients and families. So the majority of the lecture is going to be on palliative care. And I think the first thing we can do is debunk a few myths about palliative care. So it is quite poorly understood and underutilised by patients and sometimes by health professionals as well. Because someone's receiving palliative care, it doesn't mean that they can't have active treatment at the same time. They don't have to be actively dying, and it's not just for people with cancer either. It can be anyone with any kind of life-limiting chronic illness. Really what it is about is symptom management and trying to maximise quality of life as opposed to quantity of life, although sometimes those things will go together. And it can be practiced by lots of people in different settings. So those of you who've done your GP placements this year, I think you'll find some GPs do lots of palliative care, and you might have seen a lot of it, and some won't do very much. So hopefully between that and then your medical rotations last year, you've seen a little bit of how this actually works in real life. And it can be in the hospital, it can be at home, it can be in a hospice or an aged care facility. So it's really applicable across lots of settings. And there are some medical aspects that we're going to talk about that are quite different to what you're thinking about in other areas of medicine, because the goals of care are different. We're really talking about symptom control and not about cure. And what I've done throughout this lecture is I've linked down the bottom some useful resources for you guys to go and have a look at later as well. So the first thing we'll do is go through common symptoms in PAL care patients. So I think this is the stuff that's likely to come up on the written exam. Anything that you've got that is difficult to control should be discussed with a specialist palliative care team. So that's a good thing to throw out there in the OSCE. If you're getting stuck on how you might manage a symptom, just refer them to palliative care and you'll probably get marks for doing that. So the first thing to think about is pain. This really nice diagram came from the therapeutic guidelines. There's a whole section on palliative care there that I'd really recommend you go and look at, because it's got most of the medication related stuff and also sort of general concepts about treatment in palliative care. And I think the important thing to recognise here is that the physical stimulus is only one aspect of what's actually causing the pain in a patient. And in someone in a palliative care setting, this is really important because there can be lots of social and cultural things that are going on at the same time. The patient might have lots of other symptoms. They might be struggling psychologically. So you need to think about the whole patient and a holistic care. And that's really what general practice is about. And palliative care is a good example of how that can be used. So in terms of managing pain in palliative care, the first thing you should do is try to find out as much pain as you can. Take a really thorough history. Does it sound like it's nociceptive or neuropathic pain? Is it more of a chronic pain kind of problem? Have they tried anything? Did it work? And what impact is it having on their quality of life is really the thing that's important to assess in this situation. This little diagram here is just to remind you of the classification of pain. Chronic pain is sort of a separate entity and is not really included on this one. But you can go over that in your own time, because I think we're going to run out of time today. So in terms of considering management of pain, we should think about whether we can identify and treat a cause, and this could involve drugs, surgery, radiotherapy, all sorts of different things depending on the cause. There might be lifestyle and non-pharmacological interventions that can help. And then we should think about what kind of pain medication is likely to be effective based on the cause of the pain. So nociceptive pain responds well to really conventional analgesics like paracetamol and NSAIDs and opioids. And neuropathic pain tends to respond well to some of the other drugs that you might have seen, like gabapentin and pregabalin, which is Lyrica, and tricyclic antidepressants as well. And I've highlighted the next point because I think it's kind of unique to palliative care that opioids tend to get dragged in earlier and they stay as part of the management longer term, where you've probably been taught that we don't like to keep people on opioids because they tend to get tolerant and they get dependent on them and then you can't get them off them. We're less worried about that in a palliative care setting because they are really effective for controlling symptoms, and often these people will be on them for the rest of their lives anyway. So a typical pain regime for a palliative care patient would be having a long-acting opioid for a kind of baseline pain control, then a PRN opioid for breakthrough pain, plus minus an adjuvant. And you should also always consider an aperient and an antiemetic to manage the common side effects of opioid medications. So non-pharmacological treatments, this is not an exhaustive list at all. This is just some ideas to get you thinking about the kinds of things that can be offered to patients that are not just medication. So I think psychological support is really important for these patients. This might be counselling, it might be considering if the patient has depression along with whatever medical illness they do have, if they've got social and financial concerns, and then psychotherapies and complementary and alternative medicine are really useful in this sort of setting. And there's a variety of physical therapy interventions we can use as well. So our non-opioid analgesics, your first line for most things is paracetamol, which is really good for mild to moderate and especially kind of soft tissue and musculoskeletal pain. The considerations here are really liver function. We know that paracetamol in overdose causes dysfunction of the liver. So if someone's got a really terrible liver already, you'd be careful about how much paracetamol that you were giving them. And often if you give paracetamol with an opioid, you'll find that maybe the paracetamol is not actually providing much extra benefit and it's just giving the patient more tablets to take. So you could consider taking it off and seeing if the situation gets any worse without the paracetamol. Another option here are NSAIDs. These are things like ibuprofen, diclofenac, and these are good particularly for inflammatory type of pain and bony metastases. Considerations here are all of your common things that you know already about NSAIDs in terms of side effects, so what their renal function is like, if they've got peptic ulcer disease, hypertension and heart failure. And we find that older patients are more likely to have adverse effects associated with NSAIDs as well. Something you could consider here if you're worried about someone getting gastroesophageal reflux with their NSAID would be to put them on a PPI as well to try to inhibit that. So opioids are probably the main analgesic that you'll see used in a palliative situation. These are good for moderate to severe pain of essentially any cause. What you should think about when choosing an opioid is whether you want it for maintenance, so whether it needs to be long-acting and kind of cover a baseline level of pain across the whole day, or whether it's for breakthrough pain, say it's when the patient is moving, they get a lot more pain, or whether maybe it's needed for both. That will determine whether you want an immediate or a modified release formulation of the opioid, and you should consider the route of administration as well. An oral opioid is a really good start for most patients, but in palliative care, as people get more unwell and they're not really able to take things orally sort of in the end of life stage, then you can consider subcutaneous opioids as well. In renal impairment, opioids and their metabolites can accumulate, and this causes more adverse effects, and the best one to choose in this sort of situation is fentanyl. If it's in bold, I've highlighted it because I think you should know that for the exam. So that's a good one to know. And in any patient with hepatic impairment, you just want to be careful to start at a really low dose and then just go and titrate up slowly. We don't give Targin because the naloxone component in there can cause accumulation of metabolites. In palliative care, opioids have been shown to improve quality of life, and you might have some issues sometimes with patients not wanting to start on an opioid because people hear lots of things about getting addicted to opioids or being given an opioid meaning that they're in the end stage or you think they're going to die. So sort of being able to debunk some of those concerns from patients can be really important as well. With any drug, you should start with a small dose, see if it's working, monitor for adverse effects, and then you can always increase it later if you need to. So there's this really useful document that helps you compare all of the opioids. This is just oral morphine to other oral opioids, but there's also oral to IV and different IV formulations compared to each other. And I don't think you need to memorise any of this by any stretch, but knowing that it's there as a resource for you to use is a good thing. And something to highlight on here is that a lot of opioids, there's a real variation in the strength of the drug that you're giving here. So if you look at oral morphine to oral codeine, for example, you need to have a lot more codeine to get the same effect as the oral morphine. And then if you look at something like tapentadol, 300 milligrams of tapentadol is the same as 100 milligrams of morphine, which is a lot of morphine. So I think you need to make sure that you, when you're looking at a patient's drug chart, you can have a concept of how much that actually is compared to other opioids. the type of opioids that's available, this is really just a resource for you to look back at later. This is one of the situations in which you'll see brand names used a lot, unfortunately, rather than generic names. And that's because a lot of the generic names are really, really similar and it's easy to get confused between drugs. So if you've seen any of these medications, you can come back and have a look at this table and that will help you work out what they actually are. You'll see that I've divided it into short-acting and long-acting forms, and then you can see the various formulations of the drugs as well. So there's lots of tablets in there, oral medication. Some come as a liquid, some come as a patch, some come as a long-acting tablet. So how to choose an opioid? Think about allergies and adverse effects, and if a mild adverse effect could be managed. So often you'll find it on someone's drug chart that it'll say that they're allergic to morphine, but when you ask them about it, it'll turn out that they actually vomited when they had morphine, and we know that that's a really common side effect of opioids. So you can give them an antiemetic with it and that might control that well. You should choose an oral opioid where possible. You should think about whether the medication regime is something that the patient can actually adhere to and not make it overly complicated if you don't have to, and think about renal impairment, and if there's renal impairment then we use fentanyl as a general rule. You should start with one opioid, and morphine is first line unless there's a reason not to use it. The breakthrough dose should be 1/10 to 1/6 of the 24-hour dose. You should prescribe a regular aperient and a PRN antiemetic. And that just gives you in the corner some kind of common starting doses of morphine that you might see. Ordine is the liquid short-acting oral morphine. MS-Contin is the long-acting oral morphine. So common side effects of opioids, the ones that are in bold here, sorry, it's a bit hard to see in this font, are the ones that I think come up a lot. So things like nausea and vomiting, sedation, and particularly respiratory depression, urinary retention and constipation are probably the ones that you'll hear of the most. But just beware of this in patients who are on an opioid, that complaint of any of these symptoms could actually be due to the drug. So adjuvant analgesics are really useful in the situation of neuropathic pain, and also if you've got pain of any source that's not really responding well to conventional analgesia that you've tried, and usually that's used in conjunction with an opioid. This table you can probably tell has come directly from the therapeutic guidelines and includes some of the common drugs that we would use in these sorts of situations. So you can see that there's some tricyclic antidepressants up the top. Then we have gabapentin and pregabalin here. And then we've got clonazepam, which is a benzodiazepine here. And then we've got another antidepressant down here. Things to think about are that gabapentin and pregabalin are renally excreted. So you'd want to start with a small dose in a patient with renal impairment or a frail patient. And with any of these medications, introduce it at a low dose and increase it slowly. If you look at this table, it gives you a bit of a guide as to how that might be done in practice. And that's just to minimise the likelihood of adverse effects. So it's actually really common in palliative care to have refractory pain that has not responded to whatever treatment you've tried. So in this sort of situation, which could be a thing that comes up in the OSCE, that you've got a palliative patient who has pain and they've been on a certain pain regime and it's not working and it's really bothering them that they can't get control of it, you should start by thinking about whether the drug is actually appropriate for the likely mechanism of pain, whether the patient is actually taking the drug at the appropriate dose and frequency, and there could be a number of reasons why they're not doing that. If they're not, maybe it's due to adverse effects, maybe it's because they're worried about adverse effects or addiction or tolerance. The regimen might be too complicated if there's too many different drugs, if the dosing is too frequent, or if there's lots of variable dosing instructions, say in the event of this, do this, or in the event of that, do that. That might be just too much for some patients to actually get a handle on instructions that vary depending on different situations. And it might also be that the patient just doesn't understand what they're supposed to do, which might be due to a language barrier or an intellectual impairment, or maybe they've just been given really bad instructions by whoever prescribed them the drug, which is not actually that uncommon. Or it might be that there's anxiety or depression or some other kind of psychological barrier that's preventing the patient from actually taking their medication. There might also be a physical cause, such as a pathological fracture for pain that's been worsening, so beware of that and think about it. And it might also be that some of those other things in that first diagram with all of the things influencing pain have been exacerbated. It's not actually the physical source of the pain that's getting worse, but it might be a psychosocial problem, or maybe they're not sleeping well, something like that. And this is a time when you would definitely consider specialist palliative care referral if someone's got pain and you just can't get on top of it. So the next symptom to talk about is nausea and vomiting. And I think the thing to distinguish in the history here is whether it's actually nausea or it's vomiting or it's both, because it's very common to have nausea without vomiting. It's uncommon to have vomiting without nausea, but it can occur in certain situations, so it's good to make that distinction. And you want to know whether it's intermittent or whether it's persistent. And if it's intermittent, if there's a particular thing that triggers it all the time, that will really help you to get control of that symptom. You should choose a drug based on the likely mechanism of the nausea and vomiting, which we'll talk about in a minute. And often if someone's getting fairly frequent nausea and vomiting, it can be better to prescribe a regular drug rather than a PRN drug, because if you wait every time for them to vomit and then you tell them to take medication, they're going to be feeling nauseous a lot of the time, and that can be pretty miserable. So if it's only very, very occasionally, by all means, you could give them a PRN drug, but if it's fairly regular, give them something regular. So I think this is probably the one slide, if you're going to remember anything from this lecture, this is the one to learn, is when to use different antiemetics. And essentially this is based on the mechanism of action of each drug and how that interacts with the cause. I've highlighted in bold the ones that I think are really important for you to know, because these are definitely things that have been known to come up on exams in the past. So if someone's got poor gastric emptying, a prokinetic drug to help things move through the stomach will really help. So these are things like metoclopramide and domperidone, which are dopamine antagonists. Gastroesophageal reflux can be treated with your standard treatment for reflux. Constipation can be treated with a prokinetic drug like metoclopramide, or also haloperidol, which is a typical antipsychotic. Central causes, these are things that affect the chemoreceptor trigger zone in the brain, which might be related to drugs and chemotherapy or metabolic disturbances. Things like haloperidol, metoclopramide and prochlorperazine work really well in this situation. For vestibular or vertiginous kind of nausea and vomiting, then things like prochlorperazine and promethazine and haloperidol are the most effective. Sometimes vomiting can actually have a psychological cause. This has definitely come up as a question before in some of the released past papers. And I think the situation is that someone is on chemotherapy for breast cancer or something, and then every time before they go to chemo, they get really nauseous in the morning and they start vomiting. You can actually just give them something to calm them down, like a benzodiazepine, just on that day to help mitigate that. For intracranial causes like raised intracranial pressure or a direct effect of an intracranial tumour, dexamethasone is the first line drug there, because it will actually help to reduce tumour edema and decrease the size of that tumour, and that can help to reduce the pressure and therefore the vomiting. And then you can give haloperidol as well in that situation. For chemotherapy or radiotherapy induced nausea and vomiting, ondansetron is probably the most effective one, and then if that wasn't working, you could try dexamethasone. Sorry guys. So spinal cord compression usually occurs in cancer patients, and it's due to vertebral metastases that extend into the epidural space and push on the cord. Usually occurs in the thoracic region, but can be anywhere along the spine. And the presentation of this is usually worsening or new back pain. It might be worse with things like coughing and bending and sneezing that are causing that compression on the cord to become worse. There might be lower limb neurological symptoms present and bowel and bladder dysfunction, and there might be anaesthesia around the perianal region. So if anyone is describing kind of bilateral lower limb neurology and worsening back pain, you should have spinal cord compression really high up on your list of differentials. This is an important one to recognise, because if you don't treat it, it can obviously result in serious neurological damage. And the treatment will depend a little bit on the patient and how well they are. So we can consider things like surgical decompression and radiotherapy, which will be appropriate for people who've got reasonably good quality of life, or they're not sort of expected to die very soon. And then as more of a palliative kind of treatment, we can give dexamethasone, again, to reduce the swelling and the size of that tumour in order to relieve some of the pressure on the cord. Bowel obstruction is also really common in palliative care, again, usually in cancer patients, and it could be due to a tumour in the bowel or something outside the bowel that's pushing on it, or peristaltic dysfunction, and the classic one where that occurs is in ovarian cancer. And sometimes it might be that they've got bowel obstruction that has absolutely nothing to do with the cancer that they've got, which could be due to adhesions from previous surgery or a volvulus or anything else that can cause bowel obstruction. The management will really depend on the goals of care and whether or not an invasive treatment is appropriate for that patient. But even if you can't actually relieve the bowel obstruction, patients can still sometimes survive for weeks. So we need to have a method of being able to keep them comfortable over that time. So active intervention of bowel obstruction would be things like surgery, chemotherapy, radiotherapy, depending on the patient's situation and advice from specialists. And palliative things we can do it to give dexamethasone, hyoscine, which is buscopan, to relieve cramping pain, We can give ranitidine, which is an H1 receptor antagonist, so one of your old kind of sedating antihistamines that inhibits secretion of fluid and electrolytes into the gastrointestinal tract, which can help reduce sort of volume and frequency of vomiting, because if there's a total bowel obstruction and fluid can't go down, it's going to have to come back up again. So if you can minimise the fluid that's going into the gut, then that will help reduce the burden of vomiting. And we can give haloperidol as well to reduce nausea and vomiting. As I mentioned before, in a bowel obstruction, we don't want to give prokinetic antiemetics, things like metoclopramide and domperidone, because that can actually kind of impact the obstruction and make it worse. So it's not, we use it in constipation, but we don't use it in total obstruction. So it's a good idea to kind of make that distinction. Sometimes something like a nasogastric tube can be helpful to relieve ongoing vomiting, but it depends a bit on the patient's situation and whether or not they're likely to tolerate that if you consider it. Delirium, I'm not going to talk about today because I think someone will talk about it in the psych lectures tomorrow, but just in brief, environmental modification is the first line thing to do. And then if you can't get control of it with that, you can use pharmacological management. The key thing here is that pharmacological management needs to be used when it's for the benefit of the patient and to keep them calm, and not because they're annoying the nursing or the medical staff, which I think does sometimes happen in practice and probably really shouldn't. Hypercalcaemia is fairly common in palliative care, usually in the context of malignancy, which might be due to bony metastases causing breakdown of the bone structure, or paraneoplastic syndromes, particularly in lung cancers, or sometimes it's the cancer itself. If it's severe, and this is your corrected calcium here, if it's more than 3 millimoles per litre, the first thing we do is fairly aggressively rehydrate the patient with lots of normal saline, nothing that has calcium in it. And then you can also give an IV bisphosphonate. Salcitonin, which is salmon calcitonin, I never heard of, but I put it in here because it is literally the hormone that they take from salmon, which I thought was a bit strange, and can be used in a life-threatening situation with a bisphosphonate. But I don't know if anyone's actually ever seen that used. Theoretically, it's possible. Longer-term treatment might sometimes be necessary if someone's got a cancer that's causing ongoing hypercalcemia, and in that case, you would give them either an oral bisphosphonate every day, or you can give them an IV bisphosphonate every couple of weeks, just to help keep the calcium level down over a longer period of time. So this bit up the top here is sort of your emergency management if someone's got really high calcium now, and then this is your longer-term treatment. And you should remember from sometime, maybe third year, stones, bones, moans, groans, and psychiatric overtones. Yeah, I can see some nodding. That's good. That's the sort of symptoms that you associate with hypercalcemia. So remember to think about it in these kinds of patients. Pruritus, I think this is the last symptom-based one, is really common in cancer and in non-cancer advanced illness like end-stage chronic kidney disease and hepatic disease and cholestasis. Can also be drug-related, can just be related to dry skin and poor skin care. And I think it's easy to kind of underestimate this as a symptom, but it can actually be really distressing and stop people from sleeping, and in some situations it can actually be worse than pain. So don't underestimate it, think about it, and there's lots of things we can do to treat it. So the first thing to do would be to treat the underlying cause if possible. So if it's really obvious that the patient has got dry skin, or that might be a side effect of the medication that they're on, that's a pretty easy one to manage. Good skin care is really key. And then systemic therapy might be required, and what you'll choose depends on why you think they have itchy skin. So there are some examples of different causes of itch here, and then the medications that you can use. Some of these are really strange things that you wouldn't actually think would make any difference, like rifampicin, you might remember, is an antibiotic that's used for treatment of tuberculosis, but it's actually very useful in cholestasis as well. And adding on dancetrone to an opioid or changing the opioid is good for opioid-induced itch as well. Sometimes you'll have an itch that sort of doesn't really seem to have any particular source, or it's not resolving with any other treatment, and these drugs down the bottom here, which are mainly antidepressants, and then a benzo for sleeping, can be really helpful in that situation. So I've just got a few little OSCE tips of palliative care, because I absolutely think this is something that could come up as an OSCE station. It didn't last year, but maybe that means you guys will get it this year. And these are just some ideas of things that I thought might come up as a possible palliative care OSCE. So I think regardless of what the topic is, there will be a big focus on communication skills. So make sure that you practice how you're going to deal with an upset or a grieving patient or someone who's angry, how to handle uncertainty about things like diagnosis and prognosis, and how to explain things to patients in a way that is really easy to understand. So I won't go through these scenarios now. This is sort of something for you to look at later when you're starting your OSCE practice to give you a bit of a starting point as to where you might go with palliative care type stations. So the next thing I thought I'd talk about briefly is advanced care directives. And I think this is a fairly likely one to come up at some point in the exam or the OSCE because the laws around this have changed in the last couple of years. So what an advanced care directive is the legal document part of advanced care planning. So advanced care planning is a discussion-based thing, really, where you talk with a patient about what they would like to happen to them in the event that they become unwell and they can no longer make medical decisions for themselves. And then the advanced care directive is the place where that is actually written and can therefore be followed if that situation eventuates. And there's two types. It can be an instructional or a values directive, and they can be made by anyone as long as they've got decision-making capacity at the time. Once it's been made, if the patient wants to, they can revoke it or they can change things on it, as long as they've still got capacity to make decisions. So it's not something that has to exist for absolutely forever if the patient changes their mind about the kinds of treatment they would or wouldn't want. So an instructional directive is a legally binding document that specifically says what treatment someone does or does not want. And the requirement for health professionals is to make a really good effort to find whether one of these exists. And if they found it, they must follow it and not give anything that the patient says that they don't want and give anything that the patient says that they do want if it's medically reasonable to do that. A values directive is a bit less kind of specific, and really it talks about values and preferences, and it's useful as a guide for the medical treatment decision maker, which might be the power of attorney or it might be the VCAT guardian, to make a decision in the patient's best interest. So it's talking about in general the types of things that the patient would or wouldn't want, or their beliefs, but not sort of specifically, yes, I want to go to ICU, no, I don't want to be intubated, that kind of stuff. Those things would be in an instructional directive. To make an advanced care directive, you have to complete the correct paperwork, and it can be witnessed by a doctor and then a second person, and the responsibility of the two witnesses is to make sure that the person has capacity and they're voluntarily making this directive. So end-of-life care is kind of a subset of palliative care, and really the goals here are about keeping the patient comfortable, which involves a lot of the symptom management stuff that we just talked about, and some environmental things like having a quiet room, aiming for out-of-hospital care if that's something that the patient and the family would prefer, which it often is. Informing the patient and the family of what they can expect to happen within the next few days, because that can be really scary for both the patient and the family, especially if they've deteriorated very suddenly and there wasn't a lot of advanced care planning and kind of discussions about this sort of thing before the event that someone's actually kind of dying. And we want to encourage the family to spend time with and to talk to the patient, even if they're not responding verbally, because there's some evidence that the person actually does recognise that there are people there, even if they're not sort of verbally able to respond. It's nice for both the patient and the family to encourage them to spend some time together in those last few days. I think something that I've been taught as some very wise people is it's a good idea to ask a patient or their family about what questions do you have rather than do you have questions. And that's a very subtle difference, but I think this first phrase of what questions do you have is really opening it up to the patient or the family to be like, I know that you have questions, please ask me your questions, I want to listen to your questions, rather than do you have questions. It's very easy for someone to say, no, it's fine, and then go home and think about it and say, actually, I have all of this stuff that I want to ask about. So making sure that you keep the door open for people to ask questions, because this is a really kind of scary and confronting situation for people, is a really good thing to do. End-of-life care is really as much about not doing as it is about doing. So often you can cease a lot of the patient's regular medication, including any oral medication if they're not eating or drinking. Not giving certain treatments is often appropriate. Check if there's an advanced care plan. Otherwise, a discussion should be had as to what will and will not happen in those last few days. And then usually if their patient's in hospital, the nursing staff will stop taking vital signs on them. But I think the important thing to remember is that that still means you have to go and check on the patient and make sure they're okay and make sure that they're not in pain. Just because you don't have to sort of regularly go in to do vitals every 4 hours doesn't mean that you can just kind of leave them there and ignore them. So I think something that's hard unless you've seen it is how you know if someone's likely to die within the next few days. And I think that there's a phase that sort of leads up to this terminal event over the few weeks that you might be able to identify. And if you identify that someone was in this stage, then this is when you would want to have a discussion about the dying process and whether the patient would like to be cared for and what kind of help the family is going to need in order to facilitate that before you get to the point where they're actually likely to die sort of within the week. So you might see that the disease is progressing faster, like there's a tumour that's getting a lot bigger, they're starting to lose weight really rapidly, their other symptoms are getting worse. They might be spending a lot of time in bed, got no energy, sleeping a lot of the time and not very interested in eating or drinking. And in the last few days, the patient is usually completely bedbound and very much reliant on the care of other people. Often they have reduced conscious state and they're not very responsive. They can usually not swallow properly and they're not really interested in food and drink. And we don't really give oral medications during this time if the patient's not eating or drinking. You can offer them food and drink, and sometimes the family particularly will rather do this because they think that the patient is going to starve to death or they're going to become dehydrated because they're not drinking anything. But it's sort of inappropriate to force someone to eat or drink if they don't want to in this situation. Usually the urine output will really drop off and they might develop an altered breathing pattern, which we'll talk about on the next slide. And you'll see that they're peripherally kind of shutting down and becoming pale and cold. So what we can do for the dying patient in terms of nutrition and fluids is that we need to recognise that their oral intake is likely to be greatly reduced. They might be having nasogastric or gastrostomy feeding, and we should think about when the burden of having that and the discomfort of having a tube is actually outweighing the benefit of them being fed if they're likely to die within a couple of days anyway, and stop it at that stage. A good way to explain this to families is often that feeding can be quite unsafe and people might aspirate and be really uncomfortable because they can't swallow properly. So that can be a way to get around the family being like, but they're not eating, they're not drinking, we're worried about that particular aspect of things. And having a dry mouth is really common because the patient does sort of slowly become dehydrated and we can just moisten that with water. In terms of breathing, there can be lots of different breathing patterns that you might observe when someone is getting closer to dying. Might be slow or irregular, it might be rapid and shallow kind of panting. You probably heard of Cheyne-Stokes respiration, which is where you have alternating periods of apnea and then periods of rapid breathing and then going back to apnea again. And what we can do to manage dyspnea is give opioids and benzodiazepines just to kind of reduce that respiratory drive a little bit, to reduce the distress that it's causing the patient to be short of breath. Often you might notice that patients have kind of rattly breathing due to accumulation of respiratory secretions, and this is another thing that families are often quite concerned about because it sounds like the patient's very uncomfortable because of this, even though they might not be. And what you can do to manage this are anticholinergic drugs like glycopyrrolate and hyoscine can be useful, and sometimes just repositioning the patient as well can help stop accumulation of the secretions. Terminal restlessness is fairly common as well, and usually a little dose of a benzo is enough to control this, but if you can find an obvious cause, like if they're in urinary retention, put a catheter in and drain the urine, that will usually resolve this sort of symptom. In terms of prescribing, as I said, we tend to stop oral therapies, but if anything is still required, such as analgesia and antiemetics, we can give sublingual drugs still, and we can also give things using a subcutaneous syringe driver. Usually you'll find that patients don't have an IV line in at this stage because it's kind of more invasive and not providing a lot of benefit, and we can slowly trickle in a lot of drugs subcutaneously to good effect, and we're stopping anything that they don't need. So in terms of what you should do once someone has died, which could be another OSCE, I guess, that you might have a grieving family member, someone who's recently passed away, you should try and allow time for the family to say goodbye and make sure that you ask about whether there's any kind of special needs or requirements of the family. Don't sort of ask it in that way, but just say, is there anything that we can do for you? What can we do to help you? Because there'll be a lot of cultural variation in funeral practices, and I don't think you're really expected to know necessarily what those things are, but just being open to it and making sure that you offer the support that you can give is really important in this stage. Make sure that you do look after people who are grieving, and there's also a requirement of a medical practitioner to certify the death and then to complete the death certificate. Sometimes deaths will need to be reported to the coroner, but usually in the situation that someone has been in palliative care for a while and you knew they were dying and it was just sort of a slow deterioration and then they die, it's very unlikely to be a coroner's case. You guys should have been taught about this at some stage, so I'm not going to go through it today. So the last little bit of this lecture is about caring for a person with a disability, and I think if palliative care is kind of hard to talk about in lecture form because it's sort of more concepts and not really content, then this is even harder. But I've tried to make it kind of a practical guide to what you might do in the OSCE. So some terminology that does tend to come up, which I personally find a bit confusing, is a disability versus an impairment versus a handicap. So what a disability is actually a restriction or a lack of ability to do an activity in the type of manner or the standard that would normally be expected of a person. So this is a functional limitation. So this might be something like an inability to walk. And this actually occurs as the result of an impairment. So what the impairment is a loss or an abnormality of a psychological, physiological, or anatomical structure or function, which is kind of the underlying reason why someone can't do the activity. So, for example, if someone can't move their legs properly, that's the impairment, and then the disability might be that as a consequence of that, they're not able to walk. The third term that gets used is handicap, which is a disadvantage for an individual. That means that they can't do something that peers of their same sort of age would be expected to be able to do. And this might be that because this person can't move their legs properly and they can't walk, then they can't go and run with their friends or something along those lines. So I think to have an example to put with each of these to kind of illustrate the difference between them is really helpful to try and remember what that is. So, sorry, this is a bit of a busy slide. In terms of caring for people with a disability, I think the first thing to recognise is that all people with disabilities are going to be different. So you need to make an effort to find out a bit about the person and what they can do and what they can't do so that you can care for them appropriately. So things to ask about if you're meeting someone for the first time would be how they normally communicate and if they need any assistance with communication. You need to try and find out what their cognitive capacity is like. So do they make their own medical decisions, or is someone making decisions for them? Are they likely to be able to understand things that you can explain to them, or are you going to have to modify how you explain things? What is their physical capacity like, which might be relevant to the type of advice that you offer. For example, if someone has kind of limited mobility, you'll need to alter what you offer in the way of an exercise regime, for example, and what aids they need to be able to mobilise and to take care of their ADLs. I think it's a good idea to just sort of ask what life is like for the person and to try and initiate a discussion about what the barriers are for that person living well. So that might be pain, might be mobility, might be cognitive, might be other symptoms. And that will give you an idea of the things that you can kind of target in order to make sure that they're living a reasonable quality of life. And also make sure that you've asked if the patient or if the carer has any specific requests or concerns, and beware of carer fatigue, which tends to occur when people are looking after a lot of the time someone who's got quite a significant disability and a lot of needs, and carers can get absolutely exhausted in these sort of situations. I think you need to acknowledge that it's okay to be tired, to feel like you're not coping, to need to have a break, because people feel like they're indebted to their family or their friend that they're caring for, but really everyone needs a break every now and again. You can't deal with that sort of stuff all the time. So I think in the OSCE, make sure that you ask about this kind of stuff politely and be genuinely interested, and most people will not be offended if you ask about it in that kind of way. Make sure that you take into account what they say, and then if you're then asked to explain something in the OSCE, then you can kind of tailor it to what you know about the patient and what's likely to be appropriate for them. And do involve the patient, even if the carer is sort of doing all of the talking. You've probably seen this in real life as well, particularly with paediatric patients, that usually the carer will do most of the talking, but you still need to remember that the patient is the subject of the consult and the reason why you're actually having the discussions. So do involve them, say hello to them, smile, look at them, make sure that you show that you're actually interested in the patient and that they're important to you. So the last slide is just about surviving year 4. You guys can just read this where you have a couple of minutes break if you like, but please email me if you have any questions about this lecture or anything else. And all the references are on this next slide as well. Most of it came from the therapeutic guidelines because there's a big section on palliative care on there. Anything else is just referenced on the relevant slide. And this question bank, if you guys don't know about it already, you should get on that because there's a whole heap of free questions there. And I might just finish with this little YouTube video. If it will let me open it.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So I don't know, maybe that will change your perspective of how you think about palliative care, but actually misconceptions about what it is are really, really common. Thanks, everyone.